Welcome to Trinity Health IHA Medical Group Wednesday Wellness Series. This presentation is titled Surviving and Thriving with Hip Arthritis, What the Patient with Hip Arthritis Should Know. And our presenting provider is Trinity Health IHA Medical Group Orthopedic Surgeon Bryan Pack. Dr. Pack sees patients at our Livonia location on the campus of Schoolcraft College. So welcome, Dr. Pack.
Thanks a lot. Boy, that was a mouthful. So yeah, we're talking about surviving and thriving with hip arthritis, which was a play. We did a presentation on knee arthritis previously, but really what I wanted to call this presentation was getting the hop out of your hip. And my kids gave me a dad. So we'll stick with this one, okay? So our agenda tonight is we're going to talk about what is arthritis in general, because I think that's a really important topic. What is hip arthritis specifically? How do I know if I have it? That's a great topic, because I get that question all the time in the office. And how can I live with and treat hip arthritis? And just to verify, Allison, can you see my presentation still? Everything's coming through?
That's great.
Okay, great. So what is arthritis and what is hip arthritis? Well, in a normal joint, what you have with the normal joint is that's where two or more bones meet. The ends are covered with what's something amazing called hyaline cartilage, although there's often fibrocartilage structures surrounding it, such as the labrum when we talk about the hip, which we'll talk about in a minute. So you're going to get a little anatomy lesson. I'll try not to be too gross. These are held together by ligaments and capsules that keep those bone ends together and stable, right? One of the common problems we get with joints is that they become unstable, which can actually lead to arthritis. The joint is crossed by tendons, which attach to muscles, which attach the muscles to bone and move the joint, just kind of like a hydraulic system. So in a normal hip, you're going to have the ball, you're going to have the socket, you have the bony socket right here, which is part of the pelvis. You have the ball, which is part of the femur or the thigh bone with cartilage. Now, they show in this illustration from the American Academy of Orthopaedic Surgeons, not to knock our academy, but this is blue. I will tell you that cartilage is not blue and should never be blue. It's usually this beautiful white stuff, and it's usually very, very smooth, and you have some fluid inside that joint, which is normal. And then you have over here called the labrum, which is a fibrocartilage that just acts as a bumper that goes all the way around that socket itself. So that is the basic anatomy of the hip. Now, what you're seeing here is some ligaments, and then you're seeing this chunk of bone out here called the greater trochanter, and that'll come into play later in our discussion. So what is cartilage? Again, it's connective tissue found in and around joints. It's flexible, it's shock absorbing, it's lubricating, and there are several types. It is a slow to grow material with a poor blood supply. It's limited in its regeneration capacity, meaning that it frequently heals with scar like other materials in the body. So, frequently it's said that it's what you're born with is what you have, and it's kind of. Fibrocartilage is rubber-like. It's structural cartilage. It acts as a shock absorber. It's not as lubricating or essentially mobile. It acts as a secondary support and for stabilization of the joint frequently. And some examples would be the meniscus or the shoulder labrum. Again, that bumper around the bony socket. Again, when we're looking at the normal hip, again, there's the cartilage. What is hyaline cartilage? So this coats the ends of bones in major joints, and it's extremely slippery. In fact, it's the lowest coefficient of friction known to man. Pretty cool, even with all our space-age lubricants. It has a high water content and a healthy joint, and it's a very efficient shock absorber. Typically, there's about 2 to 3 millimeters around the femoral ball, or known as the head, and the socket, known officially as the acetabulum, which is just a fun word to say. Arthritis is essentially destruction of the cartilage. That can come from wear and tear, such as osteoarthritis, just normal age-related wear and tear, post-traumatic wear and tear arthritis. Inflammatory diseases can cause this as well, where they deposit things like crystals in the joint, which cause reaction and inflammation and destroy the cartilage. You can have autoimmune arthritis as well, such as rheumatoid being the most common, psoriatic or lupus. And again, there are other examples of autoimmune diseases which can destroy cartilage. And there can be structural or malalignment issues which increase wear and tear and increase arthritis. In the hip, we frequently talk about dysplasia, which means a shallow socket that can in turn overload that hip over time, and that can create arthritis as well. And then other things are infection, where bacteria can get into that joint and cause the joint to be septic, and your immune system can actually, as it's killing off the bacteria, also kill off the cartilage. That's bad, and requires urgent surgery. Fortunately, those are rare. And of course, genetics and environment also have varying degrees of participation in the arthritic pathway. So I like to think of the pathway of arthritis is just that, a cycle. And so you get all of these different issues such as wear and tear, infection, crystals, trauma, and that causes cartilage destruction. The body responds with inflammation, so you get swelling and stiffness, which then increases joint pain. That can be localized or diffuse, because if the joint isn't working right, the muscles have to do more work or work out of the way they're supposed to. And so that can cause joint pain. And then joint dysfunction changes the way you walk, changes the way the joint actually works, which can cause muscle atrophy, loss of range of motion, which creates things like osteophytes, which are bone spurs that occur around the joint, and something called subchondral sclerosis. So if you ever see an orthopedic surgeon's interpretation of an x-ray, you may see these words mentioned. Subchondral sclerosis just means that the bone underlying the cartilage gets thicker and more tough. And again, that leads to more cartilage destruction. So treatment really revolves around trying to defeat that cycle. So we went from a normal hip to an arthritic hip here. The cartilage is gone. You have exposed bone. As you get that exposed bone, it happens on both sides. So you get a narrowed joint space, meaning that you're getting closer and closer to the bone touching the bone. And you get bone spurs as a result too. Frequent question I get asked is, are the bone spurs bad? Well, they're not necessarily good and they're not necessarily bad. They're a side effect of that cartilage going away. And when that cartilage, which again is a good shock absorber, goes away, it increases the pressure in that joint. Your body is pretty amazingly well designed, and that increases the pressure. It increases the surface area by getting these bone spurs in reaction to that. And that can actually displace some of the weight and make it more comfortable. On the other hand, they limit range of motion and they dig into the tissue. So again, pros and cons on that, but they are a side effect of the arthritis itself. The way I like to think about this and the way I explain it frequently is you're going from a normal paved road. For the people in the state of Michigan, this is what a paved road looks like. I'm kidding. And then you essentially go to a gravel road over time. And by the way, that's not in this middle area. It's not like you jump from this to that. It's a progression. And so what you see is you start getting potholes in that cartilage, you start getting wear and tear, and it gets a little bumpier. And then sometimes it kind of smooths out as it gets to that full end stage arthritis. Other times that's not the case. So everybody's journey to get there is a little bit different. And again, going from normal to a destroyed hip. Arthritis is progressive. It's slow, it's really rapidly progressive, but it's typically slowly progressive and slow destruction of the joint. To date, there's no proven treatment to reduce the disease or stop the progression. However, symptoms can be managed and the function can be optimized. So do I have a question? I see patients all the time who come in with what they think is hip pain that isn't necessarily hip pain. It can be related to multiple other factors. So let's talk about what the symptoms are of hip arthritis. Some common symptoms, including morning stiffness, can occur, activity-related and weight-bearing pain, meaning that you start getting pain on the groin or the front of the thigh while you're moving. The pain can be worse at the end of the day, and oftentimes you can have difficulty leaning forward, such as putting socks or shoes on without getting that groin or front of the thigh pain. Occasionally, you can get some buttock pain or lateral pain, which we'll talk about later. You may get symptoms that are more mechanical, such as grinding or crunching, or what we call crepitation on range of motion. That's a cool word. And occasional ratcheting. And that word is onomatopoeia. That is a word that represents exactly what it feels like. You'll feel it just clicking as you move through range of motion. So not unlike a ratchet or a wrench. You get loss of range of motion frequently, though not always. The toes start pointing out frequently with the leg rotating outward, and you may get limitation of your walking and daily activities, especially in late stages of arthritis or in acute flare-ups. And you may get back or knee pain, which makes this kind of sometimes difficult to diagnose. And frequently we'll see patients who have seen other doctors to work up their back or work up their knee or work up hernias, when in fact it was the hip causing the problem. Frequently we'll get people with a hernia that actually have a hernia and don't have hip arthritis. So we'll talk about that workup as well, not of the hernia, but of the hip itself. It tends to be insidious, meaning that when you ask a patient, hey, can you remember anything that set this off? They'll usually say, no, it just kind of came on. Or I was playing some basketball with some friends, or I went golfing and I twisted and it started hurting about a day or two after that. But it can be sudden. You can all of a sudden twist or feel a pop, and then all of a sudden everything goes the wrong way. It's slowly progressive again, but occasionally can be rapid. Often sudden increase in activity brings it on, but it's not necessarily. Typically it's localized, but it can be relatively diffuse too. And it depends a lot. I mean, we think about anatomy in terms of how the nerves work and where they usually are, but there can be some variation to that too. And it's not uncommon to get pain from the hip radiating to the knee. That's always a fun one to discuss with patients because you essentially have to convince them. So where is my hip? I think the perception of where the hip is for a lot of folks is different than where it actually is. So I drew out here, this is really your low back. We get a lot of patients that come in and they say, well, I've got hip pain, and they'll point to their lower back or their flank. That you're not going to get pain from the hip here unless you have a really bad hip that is then contributing to that back pain and the way you're walking and then causing spine arthritis and muscle pain because of how unbalanced your gait is. The lateral hip is on the outside here. So this is not the joint. Commonly, people think that it is, and for good reason, right? We've been taught that's our hip forever. But typically, conditions that are going to affect the lateral hip are going to be bursitis and tendonitis and referred pain from the back, although hip arthritis can cause that pain as well. From the front here, the hip joint is going to be more in the groin and the anterior aspect of your hip right here. So the ball and socket is actually right here. The outside of the femur, the thigh bone, is called the greater trochanter. That's right here, and that goes all the way down to your knee. Hip joint is, again, things that can cause hip joint pain are going to be arthritis, avascular necrosis, tendonitis, referred pain from the back, and those types of things. And we'll talk about these. You can also get front of the thigh pain. This is a common complaint with hip arthritis. The whole front of your thigh can hurt. And sometimes these patients don't even have any groin pain. It's just right on the front of the thigh, and you rotate the hip the right way. And that, of course, sets everything off. So how's it diagnosed? It's based on an evaluation. I have a lot of patients that ask me, the first thing when I walk in the room is, well, what do the x-rays show? Well, we have to do an evaluation. That's really important. It's not based on an MRI or imaging yet. Okay, so we take a history, we ask about your symptoms, we do a physical exam, there's imaging, and very occasionally we have to do some labs to look at things like rheumatoid arthritis, gout, or infection. What can you expect if you go to the doctor's office? A complete history, possibly a survey. Okay, surveys, by the way, a word on that, are being increasingly used to assess how severe your arthritis is or how severe your symptoms are. And that helps actually in terms of the shared decision making with you to come up with the right plan, because we know what surgery can do, we know what conservative management can do, and finding the right answer for the patient is part of our job in helping you make the right decisions that are right for you, by the way. Physical exam includes looking at how you walk, looking at your range of motion. There's a little pushing, a little prodding, and really what we're checking for is some tenderness around the joint itself, around bones and bony prominences, things that stick out, or tendons. You may see some special exam tests to exclude other joints. So the orthopedic doctor may look at your knee, may do some tests of your spine to see if that's what's causing the pain. So don't be surprised by that. The imaging gold standard is a standing weight-bearing x-ray. Don't be surprised that if you've had an x-ray of your hip that was lying down, you're going to be asked to get another x-ray to weight bear, and we'll talk about why that's important. It's cheap, it's low radiation, it's quick, it's a heck of a lot less radiation than, for instance, a CAT scan. It's accessible, readily accessible, and it usually tells us what we need to know immediately in the office. Basically, when you're standing, you're compressing those joint spaces. If you're lying down, that leg may be weighing down and pulling that hip apart. If you stand on it, it's going to compress, and we're going to get a pretty accurate view of how much cartilage is still there in that space. You rarely need an MRI, and you seldom need any advanced imaging at all. Most of it can be done right in the doctor's office. So what does a normal to arthritic hip look like in terms of the x-ray? So this is a pretty normal hip. Now, keep in mind that I can't share actual patient photos with you. So this is a generally licensed photo of the best looking hip that I could find. Okay. So what we're looking here is this is a right hip. This is a left hip. If you can see that pointer. The space in between the bone is what represents the cartilage. Again, the slippery stuff that goes into the bone that makes the joint in the first place. We're looking at the thickness of the bone here. We're looking for any bone spurs. I would argue that this hip actually has a little bit of bone spurring there, not terrible, but it's all in all a pretty normal looking hip. And that's going to look like this if you're looking at it in cross section, which hopefully you're not. On the other hand, an arthritic hip is going to look more like this. So again, here's the right. Here's the left. Both are bad on this one, by the way. And we're looking at the pelvis, the spine, the lower spine at least. And there's the ball, the femoral head. There's the socket. And you can see it's kind of hard to make those two out. There's not a separation between them. And that's because the cartilage is gone. You'll also see some changes sometimes in the bone right here. This is called a subchondral cyst, which just means that the fluid is actually dissecting into the bone over time. And it just, again, another problem with arthritis. But this is a bad looking hip. And this would be represented in this picture here. So here's normal on the left. Here I would call moderate. This is a patient that actually has a hip condition called impingement, meaning that their socket protrudes a little bit more. It's actually the opposite of someone who has a dysplastic socket where the socket's a little shallow. This socket actually protrudes a little bit more. And so what's happening over time is that as this hip moves, I'm pointing at it with my finger, that's not helping a whole lot. As this hip moves back and forth, this part right here will impinge against here easier, and that will create what's called a labral tear, which is that bumper I was talking about. That'll delaminate, and then it delaminates the cartilage of the hip. And eventually this patient is going to develop a pretty bad hip arthritis. Right now, it's just moderate because there's a little bit of joint space narrowing and there's some bone spurs around it. And again, here's that advanced just side by side, so you can kind of get a view of what that looks like. So if you see someone and they say, oh, you need a hip replacement because you've got advanced arthritis, and you see your x-ray looks like this, maybe get a second opinion. Okay. This is bad arthritis. And this, I told you I would talk a little bit about avascular necrosis, another condition that can create hip arthritis. This is where the ball itself, the blood supply has been compromised at some point. There are lots of things that can cause that, including excessive alcohol use, oral steroids, can cause this. And what happens is the blood supply gets compromised to the ball. So here's a normal looking ball. That bone actually dies underneath the cartilage, and eventually it collapses. And when it collapses, it leaves this little, what we call a subchondral fracture, and then it flattens out. And that subchondral collapse and fracture, then you can imagine this is truly a square peg in a round hole, and you're gonna get destruction of the cartilage around it. So this poor patient, I'm sure, is suffering and hopefully got a hip replacement. So why not an MRI? Number one, it's not comfortable for many people to obtain. Okay. It may find incidental benign pathology that requires not so benign additional workup, right? It could find something that looks kind of funny. So now you got to have a biopsy or something like that. That's rare, but it can happen. And 9 times out of 10, it's negative, right? For that. So it's not necessary. It doesn't change the management. So if you have arthritis of the hip, the arthritis kind of takes precedence over any other pathology on the hip, except for a few exceptions to that, and we'll talk about that. It doesn't change the prognosis. It costs a lot of money, and it costs a lot of time. So MRI is not the answer in most cases. However, there are some reasons where we might order some advanced imaging, such as an MRI. So if we see pain out of proportion to an exam or an x-ray finding, if we have a high suspicion for a fracture, but the x-rays don't look bad or they're negative, then sometimes you can develop a stress fracture of where the ball meets the femur, called the femoral neck, and that can be something that needs to be fixed, not necessarily with a hip replacement or something, but to prevent you from eventually having a hip replacement. If there's a concern for a blood clot, again, this is rare, but an ultrasound might be necessary. And certain mechanical symptoms, especially without improvement, with PT or other non-op management, may provoke us to look at this a little closer. Any suspected tendon injury or tear where the hip is not arthritic may require advanced imaging. Any odd finding on X-ray, you got a hole in the bone, there's a chance you're going to need to have an MRI. Again, a chance, not an absolute. And then sometimes we use it to evaluate other sources of pathology, such as the spine. So we're not sure if you're getting referred pain to that hip, even though it's arthritic. The pain might fit more of a pattern of referred pain from the back, where you're not necessarily getting back pain, but getting pain radiating down the leg. And in those cases, we might order an MRI of the spine to see if there's a pinched nerve there that's contributing to your pain symptoms. But doctor, what about that bursitis? So let's talk about lateral hip pain. This is the most common type of hip pain. So it's commonly referred to as trochanteric bursitis, or called trochanteric bursitis, or gluteal tendonitis. This is a general term, and I'll show you a little bit of the anatomy here. It's sometimes an incidental finding on advanced imaging. So someone gets an MRI of the hip, and they talk about some tearing of the gluteus medius or gluteus minimus muscles or tendons. So those are muscles that attach around the hip on the side of the hip. Again, I'll show you some anatomy here in a minute, but it's commonly confused with arthritis. These conditions are rarely fixed with surgery. In fact, most of them are not fixed with surgery. You can actually make it worse with surgery. So if you, by chance, get an MRI that shows a little bit of tearing here or there, or a little bit of what we call tendonitis or tendinosis, don't expect necessarily that you would need any kind of surgery. That's good news. It's usually associated with irritation of the pressure point at the lateral hip, again, the greater trochanter, usually associated with some muscle atrophy, meaning some shrinkage or deconditioning from disuse of that muscle or misuse of the muscle in some cases. Causes inflammation of the gluteus medius tendon attachment, again, right at that chunk of bone on the outside of the hip, and inflammation of the IT band, which is a long tendon that passes from the top of your pelvis all the way down past your knee, and that can rub against the bone, which, as you can imagine, doesn't feel real great. Occasionally, you'll get a fluid collection around the irritated area, which is called a bursa, which in that case is bursitis because it's inflammation, and this is why it's called bursitis. And sometimes, I say sometimes, but oftentimes it's referred pain from the back itself. What about a labral tear? Yep, these frequently accompany arthritis, and most of the time they do not change the management. And that is because, well, we'll get more into that later, but we'll talk about labral tears in a little bit. So it's really treated by treating the arthritis. So how do we treat arthritis? Again, you have this vicious cycle. We really have to interrupt that cycle. That's really what it comes down to. So prevention of things that are going to cause cartilage destruction, avoiding high impact things, which, by the way, avoiding high impact things can also decrease joint stress in general once you've had arthritis. Treating the inflammation means anti-inflammatories or occasionally cortisone injections. Again, treating the inflammation going to joint pain. You can add additional medications that help, and we'll talk about each of these. Okay. So again, once you recall that I said there's no cure for this, but we can treat the symptoms. And so in general, that includes general well-being, mind, body, spirit, right? These are interconnected and important. And we know that they're important in terms of how you, number one, face pain, how your body interprets pain, and what kind of inflammation is going on in your body. So having a healthy diet, regular exercise, good sleep habits, active treatment of other disease processes, which actually can contribute to your arthritis. Like, for instance, diabetes and having high blood glucose can cause more damage to nerves, which can cause changes in the way you walk, which can put more stress on your hip and on your knee and contribute to arthritis as well. So treating disease processes is actually really important, and treating stressors in your life is important too. Manage symptoms, decrease stress on the joints with activity modification, weight loss or at least optimization, exercise and optimization of the type of exercise that you're doing. We want to decrease inflammation, including using medications, occasionally injections, diet, lifestyle, those things. So the main management of symptoms is decreasing stress and decreasing inflammation. And that really goes for any type of arthritis. For activity modification, in terms of reducing mechanical stress, is we want to avoid impact activities. So smooth arc of motion in general, non-jarring, swimming, bicycling, walking are all great examples of this, okay? And frequently these are better tolerated with hip arthritis as well. You want to avoid things like running, unfortunately. Now, I always tell people who love to run, if you love to run, do it. But do expect that that is going to create more wear and tear on your joints, and that can cause that arthritis to progress faster. So if you can find things that you like to do that are still active, those are really important. Probably the worst thing you can do is sit in a chair or increase your sedentary sedentary activity. There's an oxymoron for you. But anything that causes you to be less active is probably going to be detrimental in general. Weight loss, yes, this is important. However, it disproportionately affects the knees just because the mechanics there, but a nailing knee can adversely affect the hip too. We really emphasize maintaining strength. So a healthy hip is one that is reasonably strong. As those muscles atrophy, you start getting other pains. You start disusing that hip more. You start causing more stress on that hip. So it's really important to maintain strength as much as you can. Range of motion and balance optimization are also key. The worse that limp gets, the worse you're going to have, the more stress again you're going to put on that hip, and the more that arthritis and your symptoms are going to progress. So yes, physical therapy is helpful to an extent, especially for those with early to moderate arthritis. In advanced arthritis, it can be helpful for improving your balance and reducing some of that pain, but ultimately it isn't as effective on hip arthritis as it is, for instance, for knee arthritis. Again, it improves your muscle strength and balance. It improves the sense of joint stability in this case. Different from a knee where we're not talking about ligaments in the middle, ligaments on the outside. We're talking about a capsule that encapsulates that hip. We don't get as much instability from that as we do from the roughened surface of the joint itself. Improves range of motion and stiffness, and improves the function of surrounding joints, including your back and your knees. And again, it can offload the affected joint. What about bracing? I get this question once in a while. This is really not a good option for hips. I will tell you, I tried to find a great picture of this. I couldn't find a picture. They're bulky. They're poorly tolerated. They provide very little relief. They're not effective. So we don't even consider bracing for hips. How do you manage an acute flare? Remember RICE. Rest, ice, compression, elevation. You want to minimize additional stress on the joint. You want to use some gel packs or ice packs, or I can't stand lima beans. So if you take them out of the freezer and they thaw, you can't use them. So better for on the hip. Compression would include like a sleeve for the knee or an ace wrap. Honestly, compression in a hip might be like like biking shorts can help. Oftentimes a little bit of ice in there. You just don't want to get a cold burn. And then elevation to decrease swelling and pain. And then management of inflammation includes oral medications, topical medications, injection supplements, and again, change in lifestyle and diet. What about oral medications? Anti-inflammatories, painkillers, opioids, and supplements. We're going to cover all those today. So what about NSAIDs? Same as for knee. The pros are that they have a long history. They're well studied. They significantly reduce inflammation and pain. This is well supported in literature. They're readily available and inexpensive. You do not need a prescription anti-inflammatory to get the same effect as an over-the-counter anti-inflammatory. They just work differently in everybody. So one might not work as well for you as it would work for me. And we can certainly sort that out with a little bit of trial and error. The cons are that there is a black box warning that says that they can increase the risk of cardiovascular event in at-risk patients. That's really important. If you're not at risk for a heart attack or a stroke, these are very safe medications in terms of your cardiovascular health. Age by itself is not a factor. So if you're 80 years old and you don't have any kidney problems and you don't have any heart disease, it is reasonable to consider using these, and the literature does support that as well. Now, that doesn't make our nephrologist colleagues who take care of renal disease, that doesn't make them particularly happy. So there is some monitoring that goes into this as well as we get older. They can cause GI upset or an ulcer. They can cause renal disease. They can increase blood pressure. They can increase your bleeding risk. And you can't take these if you're on a blood thinner, which is a disadvantage. I made them sound really horrible, but used appropriately, they can be very helpful. So over-the-counter examples include ibuprofen, which you may know better as Advil or Motrin, which are their trade names. They're also included in other medications. So watch on labels. Stuff, especially that says arthritis, may actually contain these medications. Naproxen, which includes Aleve or naproxen, which is the prescription version. It just means a double dose of the Aleve, essentially, in one tablet. Naproxen does have a lower associated risk of cardiovascular event. So that's one of the reasons why you might consider using that instead of others. Prescription only examples, the RX is prescription, by the way, would include something like meloxicam or celecoxib, Mobic or Celebrex, respectively, in terms of their trade names. They are gentler. I don't know that that's a word. They're more gentle on your GI tract and less likely to cause an ulcer. Others, such as Voltaren or diclofenac, nebumetone, et cetera, can work to varying extents based on the individual patient. So recommendations: check with your primary care provider. Do not take with other NSAIDs. So if you're already taking Aleve, don't take ibuprofen. If someone's put you on Celebrex, don't take Aleve, right? Don't double them up. The one caveat to that is that it may be, I can't say it's exactly, but it may be safe to use a topical and an oral at the same time. We'll talk a little bit about that. Do not take if you've had any bariatric surgery unless you okayed that with your bariatric specialist. If you're on any anticoagulants, it's at least a relative contraindication, if not a complete contraindication, again, because of the risk of bleeding. And if you were to have a GI bleed while you're on an anticoagulant, that's horrible. You don't want to be in that boat. Any history or any active kidney problems. Again, there's some debate with milder forms. Talk to your primary care doctor or the person taking care of your kidneys, if that's the case. And then that's not Bryan Pack when starting, that's watch your blood pressure when starting, because some of these can elevate that disproportionately. In general, take as needed. If the pain is worse, try for 1 to 2 weeks at a time, and then wean as tolerated, and just kind of do that to knock out some of that inflammation, and then work on weaning it, decreasing it as tolerated. I rarely tell people just to stop it altogether, because you can get a little bit of rebound in terms of the inflammation and pain. What about acetaminophen? We get this all the time, like, oh, it doesn't do anything for me. Well, it actually has been shown in studies to actually be very effective. In, by the way, non-industry sponsored studies, so good studies. It's a non-narcotic painkiller. It works centrally. It works on how your brain interprets pain. It doesn't work on the peripheral nerves or in the joint itself, but it is cheap, widely available. It's generally extremely safe, not just very safe, extremely safe. It can be taken with other medications such as anti-inflammatories. And it's great, obviously, if you can't take anti-inflammatories. So for those on anticoagulants and blood thinners, you will frequently see folks on this alone. The cons are that it's not effective for everyone. There's some confusing formulations. The company that makes Tylenol in the name brand form makes a lot of money on telling you that you should take a Tylenol PM or Tylenol Arthritis, and really they're just different formulations, sometimes with a different medication in addition to that, or they're a higher dosage. So we'll talk a little bit about that as well. We want to avoid this if you have known liver problems or if you use alcohol frequently. So, if you're drinking three or more beers a day, probably not a great medication to be using because you can adversely affect your liver, and that can be a bigger problem than the kidney. Again, very safe. It's rare to have any liver problems if you take Tylenol as directed. So avoid Tylenol Arthritis. No offense to the company that makes it. It's just a more expensive version of the same thing with either a higher dosage or, again, another generic added such as Benadryl, which, by the way, Tylenol PM, that's Tylenol and Benadryl. Buy the generic 500 milligram extra strength is my recommendation. You can get it anywhere. It's usually under a different pharmacy's name. You can take up to 1,000 milligrams up to 3 times daily, safe for most people. Some people who are a little heavier, a little bigger, can take up to 4,000 milligrams very safely 3 times a day. I'm sorry, 4,000. I did not say 3 times. 4,000 milligrams total. So 1,000 milligrams up to 4 times a day. Sorry about that, to make that confusing. So again, caution if you're consuming alcohol, and do not use if you have a history of liver disease or any of the hepatitis, such as hepatitis C or hepatitis B, any active version of that. You want to at least check with your doctor first. What about opioids? What about narcotic pain medications? We highly discourage this, okay? And there's a lot of reason. There's a lot of study that's come out over the last several years that have shown it's just not a good idea. We used to do this, and unfortunately, we found that it is not only not effective in the long run, it has lots of side effects. So you get decreased efficacy the longer you take it. You get decreased pain tolerance, which increases your need for higher dosages, and it also makes little things hurt a lot. It's associated with poor clinical outcomes before and after surgery. In fact, there's even a higher risk of infection of a new joint if you're taking it a lot before the surgery. So we really discourage this. We only use it in patients in more extreme circumstances, and that's usually through a pain specialist, not through an orthopedic surgeon or even your primary care doctor, although sometimes they have to be the ones that help prescribe it. And again, these are folks who are too sick to have surgery. They have other medical complications that make it impossible to use other medications. So very, very, we want to be disparaging of the opioids. They're great postoperatively for management of acute postoperative pain, but that's really the tool that they should be utilized for. What about supplements? There are lots on the market, and there are lots that are marketed. Okay. Most commonly, glucosamine chondroitin are ones you're going to hear, chondroitin sulfate, you're going to hear things like osteobioflex, those types of trade names. Basic idea is glucosamine chondroitin and or turmeric in that. Others include tart cherry juice, maybe CBD, don't know. The take home on this is that we really don't know, okay? They can be extremely expensive. In general, there's not good data. If anything, there's small sample sizes from the company that's trying to market it, right? And small groups of people studied. There's a significant bias effect in this. Again, you're marketing it. Guess what? Your studies look pretty good. They're not more effective than placebo in a lot of cases. Placebo being a sugar pill when you're controlling for those. Just because something isn't a medication doesn't mean it doesn't have side effects. So a lot of people I hear say, well, I don't want to take an anti-inflammatory because of all the side effects. So that's why I'm taking fill in the blank. Again, doesn't mean it doesn't have side effects, particularly in your case. They just aren't studied enough to be able to say that. The US does not require FDA certification for nutraceuticals, and the vast majority are probably benign, but again, we don't know. What about topicals? So the most widely available topical on the market is diclofenac gel. It's now over the counter. It was formerly prescription only. Occasionally we do a prescription for this, but usually it's over the counter. It is an anti-inflammatory that's absorbed through the skin in the local area where it's applied. Now, it can get into the bloodstream a little bit, but not to the same extent as taking it orally. So for folks with any kind of renal disease or on again, an anticoagulant, a blood thinner, this can be helpful. It's used twice daily, and you want to use it consistently on a regular basis. It doesn't work. It really does not work if you're only applying it here and there. So you have to use it consistently on a daily basis for 1 to 2 weeks before you see significant improvement. It's shown to be effective for localized pain control for more superficial joints, meaning that it probably works better on, say, your elbow or your wrist or your knee. It's not necessarily recommended for hip arthritis, but it can be useful for side of the hip pain, such as bursitis. Pros are that it's safer than oral. Again, can be taken in limited quantities in patients with other contraindications, meaning things that you wouldn't take an oral for. It's great for localized pain. So if your hip is stiff and it's painful and you've got more pain on the outside of the hip, again, it can be helpful. They can be expensive. They're not great for all over pain or thicker tissues. They shouldn't be taken necessarily with other NSAIDs. I said I would come back to that. It depends on the patient. So if you're someone with renal disease, you probably shouldn't be taking an oral anti-inflammatory anyway. And again, it can't get into deep joints. Other topicals really can't recommend for or against, but they're available. OTCs, again, over the counters include gels, lotions, ointments, patches. Some are local anesthetics like lidocaine. So if you see a patch that says lidocaine in there, a common one would be Salonpas. That has lidocaine in it. That's kind of the secret. Lidocaine is an anesthetic. And that can be absorbed to a limited extent in that area where it's applied. Menthol type are warming or cooling sensation, and then pain relievers such as capsaicin. CBD, I have a lot of patients that swear by it. We just haven't seen a lot of data to say for or against. Some studies say that it can be good, that can help. Some studies that say it's equivalent. Some studies say it could cause some problems. The general take home on this is that we don't yet know. But everybody knows a supplier. It's the craziest thing, right? Injections. What about corticosteroids or cortisone. People say, oh, I had a cortisone injection or I had a steroid injection. That's what we're talking about is corticosteroids. We'll talk about that. HA injections such as hyaluronic acid or is hyaluronic acid. These are frequently called gel or chicken comb or chicken fat injections. That the last one isn't exactly correct, but it's the most widely used term. Platelet-rich plasma and quote unquote stem cells. So in general, no injection reverses or repairs arthritis. Most effects are to decrease the inflammation, and it's limited in the number of ones that you can do per joint per year. No surgery in the same joint for 3 months afterwards because it can increase the risk of infection, and some of these are very expensive. So cortisone is a potent anti-inflammatory. It essentially puts out the flames in the joint, but if you have a lot of embers going underneath, I can tell you that it can flare right back up. It's been used for many years. It's well proven to help decrease inflammation. An average for a knee, you're going to get about 6 to 12 weeks duration. It is less than hips, and they need to be spaced at least 3 months apart as needed. The cons are, and this is why I'm not a big fan of it, particularly in women with arthritis, is because the bone is a little bit softer, is that it can accelerate the degeneration. It has diminishing effect. And remember, I talked about avascular necrosis. It can actually promote that in a hip that's severely arthritic. So again, it can increase the blood glucose. There's no surgery on the same joint for at least 3 months. It can cause collapse of the femoral head, like I said, especially in weakened bone, avascular necrosis, and more likely in women. It must be done with image guidance, meaning ultrasound or x-ray, because the hip is a deep joint, and it's not as effective as for other joints, like knees. Works great in knees. HA, hyaluronic acid injections, HA is an important component of healthy cartilage. It's derived from rooster comb, which is purified. It's not chicken fat, okay? Originally, it was thought to nourish or lubricate the remaining cartilage. It's not good for advanced arthritis because you're not really filling any potholes because you're already on gravel. It's not recommended for hips. It's not even FDA approved for hips. What about PRP? This is where the blood is drawn. It's spun down in a centrifuge, and there are different companies that have different versions of this. The plasma, then the platelets are separated out and withdrawn. The platelets are diluted, and then it's infected into the affected joint. There's limited evidence to support this. It's not been well supported for hips. Stem cells, hot topic. This is extremely highly marketed. It's expensive. It's $3,000 to $6,000 per joint out of pocket. Incidentally, if you open up a new credit card, the minimum balance, I believe, is $5,000. So it's interesting how that's kind of priced. All the studies are highly variable. There's no standard on how they're done. There's no standard on how they're prepared. There's no evidence that it actually rebuilds cartilage or the joint. In fact, the FDA kind of came down on this because companies that are saying that it rebuilds the cartilage are being told that is not true, and they can face some pretty significant scrutiny and fines. So it may decrease the inflammation. It is considered experimental, and we do not currently recommend that. Finally, what if none of this is working? So what about surgery, arthroscopy? What if we just scope it and clean it out? In general, unfortunately, scoping it is not recommended for arthritis. You're basically clearing out good, healthy cartilage. It does not address the pathology that's there, right? So if you've got a gravel road, going out to the gravel road and picking out a few stones is not a durable outcome that has great responses, especially when you're talking about the complexity of the human body. So we don't recommend it. And even our arthroscopy partners who specialize in putting a scope in the hip and doing the right thing, they do not recommend it either. Studies on arthroscopy for labral tears with arthritis, remember I told you I would come back to this, they have shown poor outcomes. In fact, you have worse outcomes even after you have a hip replacement performed relative to those who haven't had a scope before their hip replacement. So it's highly discouraged, which is also why we don't necessarily recommend going to get an MRI to work up for a labral tear when you have arthritis of that hip based on a weight-bearing x-ray. Hip replacement is the gold standard for management of advanced arthritis of the hip. And very frankly, unfortunately, as much as I'm a very conservative surgeon, we want to only do surgery when it's indicated for patients who will improve with it, patients who want to have the surgery done. The knee, frankly, responds much better to conservative management than the hip does. Once you get to the point of advanced arthritis, if the conservative management is not working, it's reasonable to try some of that, but ultimately, the ultimate answer is replacing it. and nobody wants to hear about having to have the hip opened up and replaced. But I want to talk a little bit more about that. So hip replacement is reconstructing the hip. So when you hear of an adult reconstruction specialist, that really comes from reconstructing the hip. What that is resurfacing of the socket. So basically we clean out the socket once we approach the hip. We put a new socket in place that looks like this. So this is a system that I do use. This right here is a porous coating on it. This is a plastic liner for most, but there is some variability in this. Ceramic ball on top of a stem that is wedged in the bone. This particular stem has a porous coating that is fit inside your bone, and it comes in multiple different sizes, and the bone grows into that over time. Another characteristic of this particular stem is that it has this thing called a collar, and what that acts as is a stop point. And this particular stem has one of the lowest revision rates in the state of Michigan, which we actually track. In fact, right now it's #1. So one of the reasons that we use things like that. It restores the mechanical function of the hip, it reduces inflammation of the joint, and it improves pain and function. Hip replacement has actually been around for a long time. The original hip replacements were done by Sir John Charnley in England. Around 1960 was the actual first successful hip replacement. And throughout that time, there have been significant improvements, as you can imagine. But even the original hips done at the Mayo Clinic in the 1970s, when they looked at the 40-year data on how those patients were doing, about 83% of them were still having a good hip, had not needed to have additional surgery. So that's pretty good. Hip replacement recovery is usually about 6 to 12 weeks. Minimally invasive techniques can make the recovery faster, easier, and more cosmetic. This is often done outpatient, and it's very different from even 10 years ago. It's tied for first place for best surgeries of all surgeries performed. That includes every surgery you can think of. This has one of the best outcomes of 3 different surgeries. I said it's tied for first place. There are 3 total surgeries in that category. Durable outcomes for 20 to 30 years. It frequently, quote unquote, feels normal to people. These are some additional resources that I wanted you to have. The Arthritis Foundation has lots of information on hip arthritis and other arthritis. The American Association of Hip and Knee Surgeons is one of the professional organizations to which I belong, and the American Academy of Orthopaedic Surgeons as well, of which I'm a fellow. There's a whole guideline here that can be helpful to you. So with that, a lot of information. I do want to bring up a picture of the hip here while we're taking questions, so we can hopefully answer those questions.
Okay. All right. A lot of information. You certainly know your way around a hip. So let's see here. So we have a lot of questions already. I will kind of start at the top and we'll cruise through them. But if you have a question that you'd like to ask, you can put it into the Q&A, which is down at the bottom of your Zoom screen. So we're going to start off with, is there such a thing as a partial hip replacement?
Yeah, that's a great question. There is such a thing as a partial hip replacement. They're most frequently done in patients who have a hip fracture, and they're typically done in older patients. And that's really just replacement of one half of the joint, different from a knee where you're replacing one compartment in the joint. In a hip, you're replacing the ball itself. And so what that would entail is, let me switch here to different presenter mode. I apologize. Can you all see that? Is that better? Okay. So what a partial hip is something called a hemiarthroplasty, again, used for femoral neck fracture. That's where you have a fracture across here, and the blood supply to that ball is actually compromised. And so what you have to do is take the ball out and put a stem down inside, and then you put a ball in there that's the same size as the native socket. Great option for older patients without arthritis. It is not an option, and not a good option for patients with arthritis, and we don't recommend it. So really typically used just for fracture.
Okay. And are there any limitations on a hip replacement, like distance hiking, jogging, weightlifting, jumping?
So no skydiving. I think that goes without saying. There are some limits. I mean, if you tell your orthopedic surgeon that you want to run marathons, that's going to be discouraging to them. Not because you can't, but because you can wear it out faster. Even for hip resurfacings, which became popular in the early 2000s, and there's some problems with those in terms of metal on metal contact. Even those, we do worry about running on those in high impact activities. That said, hiking, biking, walking, even light jogging, like on grass, on even ground, can be tolerated. But keep in mind that any high impact, you will over time have a higher risk of wearing out that joint. I will tell you that I have a patient who's now in his 80s, and I have passed him several times jogging through the park, even though he swears that he does not actually jog on it. And fortunately, his x-rays have looked just fine for many years. But which is kind of funny. I did have a patient who biked from coast to coast, California to North Carolina, twice on his bilateral hip replacements. And has done very well. There's no evidence of wear on those hips at all, and so that's a very appropriate thing that you can do.
Okay, so exercise is very much can still be part of your life.
Highly recommended. Where we run into problems is extremes of range of motion, because it's a ball and socket that you're replacing with a ball and socket. Your native hip cheats. It has a big tendon that holds that ball in place. When we clean out a socket, that tendon goes away. There's no way to replace that. So the only thing holding the ball in the socket is all the muscles and soft tissue attachments around it. And so if you get it into the wrong position, it's a ball and socket. So if you bring it around, it can actually fulcrum that ball out of that socket. So there can be limitations. That's very patient specific. And a good surgeon will tell you where those limits are based on what they find intraoperatively.
Okay, this is a good transition to our next question, which is how do you tell if it's hip arthritis or tendonitis?
Based on exam. So number one, where the hip pain is located, frequently tendonitis on the front of the hip is going to be associated with, people will still say, I have a hard time bending the hip, but they'll say, I have a hard time lifting the hip to bend it. Whereas someone with arthritis is more likely to say, when I lean forward, I'm going to have more pain. So there's some differentiation on the exam. Some of it's based on where we're pushing. So if you're tender over the tendon itself, that can be more tendonitis. And then the next thing is, of course, an X-ray. And that X-ray, now you can get tendonitis with advanced arthritis too. In fact, it's very common, because when that ball isn't working well, it's just like a rusty hinge. You have to exert more pressure across the door to open a door with a rusty hinge. Your muscle has to do the same thing on a hip, which is one of the reasons it gets dysfunction. You can have both, but the X-ray is going to tell the picture frequently in terms of the if you have arthritis.
Okay, sounds like a contest I don't want to win.
No.
No, thanks. Okay, I've actually heard several people say this. So this person saying that they tried walking backwards and actually had no hip pain. Can you tell us
Yeah.
why that happens?
It's a great question. I think a lot of it has to do with activation of different muscle groups. It has to do with how you load that hip when you put weight down on it. The one that we see frequently is, if I go backwards down the stairs, it's a lot better than if I go forwards down the stairs. And again, it has to do with the mechanics. Can I give you a perfect explanation for why that's the case? No, but it's true. If we only had eyes in the back of our heads like my mom, we'd be in good shape there.
All right.
Don't trip if you try that, by the way.
Gosh, seriously. Okay, so can you rebuild fluid in the bursa?
Yeah, repeat that.
Can you rebuild fluid in the bursa?
No. And you
Okay.
don't want fluid in the bursa typically.
Okay.
The concept of bursitis is kind of an overblown concept. If you look in the anatomy text, what they'll show the tendon. I told you I would talk about the tendon here. There's a tendon that comes along the outside of the hip here, or along the pelvis, comes all the way down, goes past the knee. That's called the IT band. And then your gluteus medius muscle attaches right here on the top of this greater trochanter. And that muscle is responsible for holding the other side of your body up when you're putting weight down on this side. So you have this cantilever force that comes across here that holds that up. If that is weak, then you start doing this, and that puts pressure right over the greater trochanter here, and that's frequently referred to trochanteric bursitis. But I will tell you, doing lots of hip replacements, it is extremely rare to see a big fluid sac here. What you will see is you can see a little bit of fat around that side that acts as a lubricant between, but there's nothing that you can add to that area to improve the lubrication. Again, it's more of a tendonitis than it is, lack of fluid. or too much fluid.
Okay. Okay, so this person had a hip replacement and they think that their hip issues have contributed to some lower spine issues. Would that be
Mhm.
something you would see a patient for?
Yeah, it is. We oftentimes will do a workup of that hip to make sure. Sometimes it's an imbalance. Sometimes when you put a hip in, you either have to make that like longer to tension it appropriately or to meet the kinematic, the mechanical needs of that hip so it doesn't dislocate or so it moves better. Usually we can get them lined up within a couple millimeters of the other side. But sometimes if someone has a really rigid spine, so even in this x-ray right here, you can see that this spine kind of goes off uh, in a different shape there, in a different direction. That can affect how your pelvis sits. And those little things can affect your hip and then can affect the back. So there is some interplay there. Oftentimes it's not, but there can be some interplay. And we do work that up to make sure there's not something dysfunctional about the hip replacement too.
Okay, and can a bad knee create more arthritis in the hip?
Oh, it certainly can. Yeah. Um, Bad hip will frequently stress the same sided knee. A bad knee can stress the same side, but can also stress the opposite sided hip too.
Oh my
And
God.
we do see that because of the stresses and how the pelvis is sitting and how you're walking and the stress you're putting on that.
Okay. Do you have an opinion on regenerative therapy?
Yeah, I don't because there's not a lot of data on it. There's just not a lot of support for it. Especially for a hip, there's absolutely nothing that is unbiased, that is peer reviewed, that actually says that a hip like this is going to get better with regenerative therapy. There's just nothing. For someone who's early on in the arthritic stages, maybe I can't say it doesn't. But the honest answer is we just don't know.
Okay. There's a comment here that gentler is definitely a word.
Yeah, awesome. Awesome. By
Uh,
the way, when we talk about gentler, when we talk about PT for a hip, there is such a thing as doing too much, and I think we're familiar with that. If you tweak a hip that looks like this, you will make a patient miserable for 2 days afterwards, and they're not coming back, and then they'll lose muscle. When we talk about arthritic hip physical therapy, we're talking about gentle range of motion, gentle stretches, maybe a little bit of traction exercises to get some more motion out of that hip and improve the general function of the muscles and such around that hip. And that can improve things. But if you tweak it hard, sometimes we'll see well-meaning physical therapists, but have you start trying to do a bunch of squats or trying to do some deadlifts and that kind of thing. And I mean, that's like the worst thing you can do for an arthritic hip. So just be aware if you're getting any PT for your hip, make sure it's gentle PT to get that hip moving. Gentler,
Gentler PT.
gentler. Thanks.
Okay, so you've talked about the muscles and bones and tendons around the hip. What about nerves? Are there any nerves around the hip that impact this pain?
Yeah, there are, and that's why you can get referred pain around the hip too that can go to your knee. So when we look at the hip, the nerve supply in general that gives you the sensation that you have pain to that hip goes around the anterior capsule, the front capsule of the hip, and that comes off of what's called the obturator canal in here. You have the femoral nerve that comes over like this, and then there's a branch that comes up like this and innervates that. So if you have a lot of pain in that hip or reason to have pain, it can sometimes go across that nerve and confuse the femoral nerve to think that you've got thigh pain. So the question that often comes up, well, can you block that nerve? And right now there's not a lot of good data. I know that there are some folks that are looking at RFA, radio frequency ablation of nerves around the hip. It is not as successful, I can tell you that, as for knees. Our anesthesiologists for folks who have a hip fracture will do what's called a fascia iliacus block. You don't have to remember that, but it's a term where we do an injection up here around some of the nerves that innervate the muscles and such, and that's successful for decreasing some of that pain, but it's not a permanent solution, certainly for arthritis. But yeah, nerves around the hip can affect it. The other one that's common that we talk about is the sciatic nerve. So if you get a pinched nerve in your back up here, you have a sciatic nerve that comes through the sciatic notch here, goes along the back side of the hip, and you get radiating pain down the back of the leg. The way that you're walking can cause that nerve to hurt more, and that there are some hip conditions that can cause some of that sciatica or at least contribute to it more. And that can give you pain as well. Sometimes it's tricky to figure out what portion of your pain is coming from the hip joint versus coming referred pain from the back or vice versa.
Okay. Can you take Advil and topical Voltaren cream simultaneously?
You can. You have to be a little bit careful, certainly in caution with folks who have any kind of kidney involvement, but you can. Um, I always say talk to your primary care doctor if there's any concern.
Okay. Um, what happens 20 to 30 years after hip replacement? Can it be replaced again?
It can be. So that's the other side of my specialty is re-replacing hips. And it can be, and it depends what's going on. The most common reasons that we see hips replaced are unfortunately for fracture, meaning that someone either fell uh, years later and broke around that new implant, or unfortunately, a good portion of those fractures occur either during the surgery or immediately following the surgery. And sometimes those require additional surgeries to address. The second most common reason that we have to revise hips is for dislocation, the ball jumping the socket, and we have to change something on the socket, or we have to reconstruct things to make it more stable. Years later, plastic wear. The number one reason for revision hip used to be because the plastic will wear out. We just don't see that anymore. It can happen, but it's not the number one reason for revision anymore. And if that happens, if the bone loosens from the implant as a result, then you can re-replace the hip with bigger implants, with more screws, with more complexity to fix. Happens to be one of my favorite surgeries, but there's more complexity and there's more recovery to that. But yes, it can be fixed. And by the way, when I say that hips last, 90% of them last 20 to 30 years, that means that only about 10% of people have had a hip revision by that point. There are people who are walking around who've had hips in for, like I said, on the original Mayo Clinic series, with small balls, with bad plastic that have been in for 40 years consistently, and they're still going strong.
Okay. Can you discuss hip resurfacing versus the total replacement?
Great question. So what a hip resurfacing is where the ball itself is retained. So that means you're still putting a socket in here. That socket is a monoblock, meaning one piece metal socket with a cobalt chrome inner surface to it. And then on the femoral head, you're putting another piece, a cap, if you will, on that femoral head that's also metal. The concept there, the reason this became popular is that it can improve two things. Number one, it theoretically gets rid of wear. Okay. That was the thought process. I can tell you that metal wears. If you have a car, you understand this. Okay. Metal does wear, even if it's very highly polished. Now, you're not going to get it worn out, but it can create metal ions. And those metal ions can be toxic to tissue surrounding it and can be toxic to the body. It's rarer with nowadays modern hip resurfacing because we've become very, very, very selective in who does that. And most centers will say you should see someone who just does hip resurfacing if you're going to have that done, because it is a picky procedure. The other advantage is that, quote unquote, it's bone sparing, meaning that we're not getting rid of the ball. We're not putting a stem in. Now, there was a study done years ago, back in 2010, 2011, that looked at the function of metal on metal resurfacing versus large head total hip replacement, meaning using as big a ball as you can for the hip replacement. And they found absolutely no difference in terms of function, pain relief, or any of those goals. The other interesting thing about hip resurfacing is because the blood supply comes up along the bottom portion of this neck area here and into the ball, the last thing you want to do with hip resurfacing is compromise that, because the ball will die. And if that occurs, the whole construct will collapse. And so it means that in order to preserve that blood supply, you actually have to do a bigger approach to the hip than what you would for a hip replacement. Hip replacements can frequently be done through minimally invasive procedures, either from the front, the back, the side, to get access to the hip. Whereas with a hip resurfacing, you have to do a much larger procedure to protect the blood supply. That said, the outcomes are still pretty good. The original place that did them in England does not recommend doing them in women as much anymore because of the bone quality and that risk of collapse. Sorry, that was probably a pretty long explanation.
No, it's great. Okay, let's see. So why do physicians wait to do hip replacements on people that are maybe in their 40s, even though they're bone on bone?
Great question. The younger you are, the more likely you are to live longer, the more likely you are to accumulate more damage to that implant, and the more likely you are to have revision. And each revision has a higher risk of other complications, such as infection, dislocation, fracture, which can be quote unquote career ending, right? So we want to delay that surgery for as long as possible. That said, for someone who has end stage arthritis in their 20s or 30s or 40s, it's rarer, right? It's less common to have that occur. If your quality of life is significantly diminished by that, and your expectations are that I'm not going to go back to being a professional athlete, I think people have heard of Bo Jackson, right? In terms of his hip predicament, and he wore him out, had big problems with him. If your expectation is just to do daily activity, then a hip replacement may be an excellent option for you. But of course, we want to exhaust all conservative management options. If you're finding that it's severely affecting your quality of life and that's diminishing, you're decreasing your activity, then yeah, hip replacement is absolutely the right answer in a lot of those cases.
Okay. Bo Jackson's a blast from a past there, Dr. Pack.
I know,
Oh no,
right?
hip problems. Okay,
Yep.
so this person's saying they don't have pain in their hip, but they have balance issues. Could that be an indication of a hip joint issue?
Usually not. It's usually related to muscle or neurologic. So I usually recommend getting those assessed first. And then if you start having pain in the hip, because arthritis typically is going to be associated with pain. It's rare that you're going to find someone with arthritis who doesn't have pain in the hip to some extent. Now, if you have severe arthritis and you're just not moving the hip because it hurt or it's just socked in and you have balance issue, that's a different circumstance. So it is reasonable to assess. But most folks with balance issues without pain, it's going to be related to a neuromuscular cause. Not all the time.
Okay, so probably good to start with your primary care and they can get you to the right spot or at least
Absolutely.
spot. Okay.
Absolutely. Frequently it's a little PT. Sometimes you find that it's related to even just balance issues with your ears. Your inner ear can affect that. There's all sorts of stuff that can cause balance issues. So I'll always recommend getting that worked up by your primary care doctor. Don't ignore it, by the way. It can be a sign of worse issues that need to be addressed early. Most of the time, it's a muscular deconditioning issue or a pinched nerve somewhere.
Okay. Okay. There are a lot of questions from people who are noticing hip pain after they sit for a long time.
Yeah.
Is that,
Um,
go ahead.
it depends on the location in terms of whether it could be arthritis or not. Folks who have more buttock pain when they sit oftentimes can have arthritis more on the back side of that hip. Other patients, if they're getting on the lateral side, that's going to be typically a bursitis or that kind of thing. But advanced arthritis frequently, you can get pain in that hip, especially if you're leaning forward for a while, it just gets more and more painful. Now, if you're getting pain more in the upper buttock, that's going to be probably your back causing more of that.
Okay.
But reasonable to assess, by the way. That's something that certainly, if it's bothering you, it can be any one of those things, and that's why you assess it.
Okay. Are there any issues for people who have scoliosis to have a hip replacement?
Not necessarily. Now, there's some caveats to that. If you have a severe scoliosis where the position of the pelvis is, we'll use the scientific term cattywampus, okay? If that pelvis is off one way or the other, tilted forward or backwards, and that's a fixed angle, it can increase your risk of dislocation. There's a lot of research going into the position of the components for the hip based on your spine position, based on whether or not you have spinal disease where you have a fixed deformity of the back, whether that's scoliosis or acquired arthritis of the back, it can affect it. Most of the time, not. So for instance, when you see this patient here who has some scoliosis, you can actually see in the spine here, it's going off in a different direction. This is not something I would be concerned about as a hip specialist in terms of affecting the outcome.
Okay, how about some of those fusions or any other like disc surgeries past their
Oh, great questions. So we actually, I kind of, when we talk about hip replacement with an individual, we kind of go through their what we would expect and some of the risk factors specific to their circumstance. Folks with the fusion of their spine, especially more levels fused, do have a higher risk of dislocation. We take that into consideration as much as we can intraoperatively, again, for positioning of the socket, positioning of, because if you have a fusion of your back, that changes the position of your pelvis. Now, spine surgeons are more aware of this in modern times as well. So they're going to try not to fuse you so your pelvis is tilted way forward, right? If your pelvis is tilted way forward and your socket is over here, that ball can push out the back, okay? If your pelvis is tilted like the other way, okay, the ball may push out the front, or vice versa. So there are things that can affect that with that fusion. And again, we try to take that in consideration. For people that have a major deformity, it can be a really high risk for dislocation. That should not discourage you from getting it checked out, because there's variation in that.
Okay. There are actually several questions, and I never thought of this, but it's an interesting thought. Can your leg become shorter after a hip replacement, or is there
Yeah,
like a leg length issue that people should be concerned about?
it absolutely can be. And it most commonly it's going to be longer, and most commonly it's going to feel longer. Okay. When you look at an arthritic hip here, you've lost all this cartilage. Let me go back a couple slides here. You've lost all that cartilage, right? So you've lost 2 to 3 millimeters of joint space alone. Okay. You've lost all this. So that hip is shorter. And this course here is typically maybe a couple years, maybe 5 years. And so your body has had time to adapt to that. And what'll happen is that spine will allow that pelvis to shift, and it gets into kind of a fixed deformity. It's not stuck there usually permanently, but it gets into kind of a fixed deformity. Now, in the course of about an hour, which is about how long a hip replacement typically takes, in the course of about an hour, you've restored that space. Okay. That will feel long to people frequently for 6 weeks afterwards, because their suspension system has to adjust. The muscles in the back attached to the pelvis have to relax to allow that pelvis to level out and for that hip to feel more normal. Occasionally, again, we're holding a ball in the socket with soft tissue tension. Occasionally, what we have to do is we have to either make the hip wider, so we're creating more tension with that muscle, or longer, sometimes both. Okay. Rarely, that's not the norm, but sometimes that is the case. Occasionally, if someone is very socked in, they've got horrible arthritis. Occasionally, we can't get it all the way out to the length that they had before they had arthritis, because we would be tearing muscles or tendons or creating more problems that way. But yes, you can have a leg length discrepancy. I can very honestly state that I've had to give out 4 shoe lifts in 13 years of practice now. And so it's rare that we have to adjust it, but it can happen. And most of those are going to be special cases where one side, is dysmorphic, meaning one side isn't identical to the other side. So there's something weird about this hip and something weird about that hip, and we're replacing one of those hips. Or they've had another hip replacement on the other side with a revision. There are other things that affect leg length as well.
Okay, so it sounds like there are things you can do if that is an issue or a concern for you.
We try to avoid them. Usually physical therapy will fix any perceived leg length inequalities, meaning it feels bad but looks good. And PT can help. That the original studies, I don't think they're great studies, but basically the original study said that you had to have almost an 1.5 inch difference before you'd notice that.
Wow.
I think that's crazy. I think it depends. If you're 6'8", yeah, 1.5 inches might not make that much difference. If you're 5'2" and wear heels, that could be absolutely life-changing for you. So I think it's very patient independent.
Okay. This person had a hip replacement, looks like 5 years ago, and they get some muscle cramping. Like, it sounds like it's pretty severe cramping around that hip. And they have to kind of push on it to stop it. Is that common? And is there anything you can do to fix that or stop it from happening?
No, and it should get checked out.
Okay.
It should get checked out. There are some things that it could be your back, it could be lots of different things, but it should get checked out.
Okay. And should they go back to the orthopedic surgeon then for that appointment?
Yeah, if they trust their originally treating orthopedic surgeon, I would always recommend going back to your original surgeon. Quite honestly, a caring orthopedic surgeon, I want to know any complication or any issue that my patient is having, regardless of when or where. So I want to know what's going on, and that's number one, to help my patients, and number two, it helps me be a better doctor. It helps me understand if there's anything that I can change in terms of my technique, or any issues that we're seeing that we need to be aware of to help other people too.
Okay. Can you tell us how long a hospitalization is required for a hip replacement?
Typically, you're out the same day. Um,
Really? Wow.
if you're not, it's typically overnight. Now there are different factors that affect that, but the vast majority of patients are going to go home the same day, if not the day afterwards. So
Okay.
it's quick. It's very different. By the way, when I was a nursing assistant before I became a physician, patients were routinely in the hospital for 7 days after a hip replacement.
Oh
This
my
is not your
gosh.
grandmother's hip replacement. We're not, we used to use drains. We used to use all sorts of crazy apparatuses. This is not the way we do it anymore. You typically, it's done through, depending on the patient, a 3 to 5 inch incision off the side of the hip or the back side of the hip, glue over the top of that with a waterproof dressing. You can shower the same day as the surgery if you wanted to.
Oh my
We
gosh.
typically start everybody out with a walker initially, just for safety, just so you get the hang of that new hip. But you can put full weight on it in most cases. You can transition to a cane whenever you feel like it. Most people after a right hip replacement will return to driving a car somewhere between 2 to 4 weeks. Most people with a left hip replacement, it's as soon as they're off of a narcotic pain medication, which is usually around 1 week. So it's a very different recovery than what it used to be.
Wow. Yeah, that's amazing. Um, okay. This person is asking, do you work both on knees and hips? And I don't know the answer to that, and it's yes.
Yeah, yeah, yep. And frequently, I love fixing knees and helping people through that journey. As I said in my presentation on knees, it's a bigger journey. It's it's a lot of work for the patient. Um, Knee replacements are the reasons that hip replacement specialists do what we do. Because patients do better faster. It's a very enduring surgery. Like I said, it's the top surgery done in terms of function, recovery, and that kind of thing. But yes, I do knee replacements and love doing those as well.
Okay, and you actually gave a wonderful talk about knee replacements a couple years ago. So that's actually on our YouTube channel, and I would be happy to share that link in the follow-up email as well, so people can
Well,
watch
thank
it.
you.
Yeah. Okay. If you have moderate arthritis in the hip, can yoga help range of motion, or is that when you need
Absolutely.
worse? Okay, so yoga is a good thing.
Yeah, absolutely. You got to be a little careful. You got to pay attention. I mean, if it hurts, there's a balance, right? If it hurts, it stops. But gentle stretches can significantly improve that. Yeah, absolutely. And the more flexible you are, the less pain you're going to have in general. Not for everybody, but in general. I'll see patients who come in, and one of the first things we do is we have you lie down on the table, and then we put your hip through just gentle range of motion, just seeing where those stop points are, right? And if you're having any pain on those stop points. Frequently, patients who do yoga, who actually have acetabular dysplasia where the socket shallow, will have amazing range of motion, and their hips will frequently be in worse shape coming in for the first time to see an orthopedic surgeon than someone who just doesn't have that range of motion. So yeah, absolutely.
Okay, so I'm just flipping through here to find the last couple questions. I think we covered most of the topics. There were a lot of people who had similar or the same questions. How about posterior versus anterior method? Is one better than the other?
I was surprised this didn't come up earlier. This is a hot topic. It was a little hotter even a few years ago. And the reason it was a little hotter a few years ago is because anterior was kind of a new concept that came out late 2010, early 2000s. Okay, so 2008 through 2010. The reason was it was popularized by a trauma surgeon out in California who was routinely taking care of patients who are, I would argue, go-getters. I mean, if you can fly into a location on a private jet, get off that jet, go have your hip replacement, then get back on that jet and fly back home all on the same day, you're typically a go-getter. That said, his outcomes were excellent. And so it really attracted a lot of attention. The Wall Street Journal did an article on it in 2011 that showed that patients who had a posterior approach did really well, but patients who had an anterior approach walked on it the same day. Which for anybody who does posterior or anterior, that's an irritating article because everybody walks on their hip the same day. that's the goal. That's a gold standard. We want you moving on that hip. The general answer is no. There is not a significant difference between one or the other in general. It has more to do with the surgeon's facility with that, meaning that how good they are at that approach. You want to find a surgeon who does a good job with the approach. There are a couple things on the reason I do posterior, I do mini posterior. I'm trained on most approaches around the hip, including anterior. anterior, including fellowship training. What we see with the anterior approach is that it has a little bit higher risk of a little bit higher blood loss. It has, in one of the registries, national registries, shown a little bit higher risk of revision at 5 years, and there's a little bit higher risk of fracture. Okay. There's also a not insignificant risk of permanent numbness on the front side of the thigh. So if you're looking at the thigh, kind of the front lateral side of the thigh, in about 80% of patients temporarily, and 30% of patients permanently. And those are in good studies. So that's a side effect that I didn't want to put my patients through. It's not, again, it's not bad. And there are some advantages to it in that in the first 4 days, I think posterior approach patients have a little bit higher risk or have a little bit higher pain for the first 3 to 4 days. After that, you can't tell a whole lot of difference between the recoveries. And I've had patients who've had an anterior approach and then we did a posterior approach. I've had patients who they had a posterior approach somewhere else and I did the anterior approach. And I would say that my own experience with that is consistent. There's not a whole lot of difference, except in that first 4 days, a little bit higher risk of a little higher pain. At the same time, we give you medications to help with that, including a multimodal approach. It's not just blasting you with medications. The other thing is that there's kind of a misconception that an anterior approach is a smaller incision, and that's not necessarily true. We're frequently able to do these posterior approaches through a 3 to 5 inch incision. Now we're going to do the smallest incision that's surgically responsible. One of my Mayo Clinic colleagues really emphasized that, and that really hit home with me. I love that. But for most patients, that's going to be a small incision and a relatively quick recovery when it comes to the skin and the muscle healing. The anterior approach has been shown to have a little bit lower risk of dislocation. But then when we look at the registry data from the state of Michigan, at least the initial stuff showed that it had a little bit higher risk of dislocation. So again, it depends on the study, and it depends how well they compared populations and how matched those populations were. So that's a long answer, but they're very similar. The one that is different, I would argue, is a lateral approach where you are taking the muscle off the bone and having to reattach the muscle. That's one that I try to avoid at all costs. The only time we have to do that is if the muscle's already off. Okay, when we get in there, that can happen sometimes. Like, oh, okay, well, I guess we'll go around the front now. But with a posterior approach, you are not actually cutting muscle off bone. You're splitting the fibers, you're going in between, and usually using retractors a little bit kinder to the muscle. And again, the recovery is very, very similar with a little bit lower risk of revision and lower risk of nerve injury.
Okay, a little gentler to the muscle.
It is. Yeah. Try to be nice.
Yes. Okay.
You can go between the muscles with an anterior approach, and even one of my anterior approach colleagues who's an excellent surgeon, exceptional, I would have my hip done by him, not a problem, even with that approach. But he'll tell you that you can cause just as much damage crushing the muscle that you're retracting without going through it, versus going through it. So again, there's a lot of propaganda for both approaches out there. I always tell people, buyer beware. Go to a surgeon who knows what they're doing through the approach they're using, and they're confident in it. That's the most important thing. And the other argument I would make is that go to someone who isn't just doing it because it looks good on a billboard, but because you're doing it and know how to get yourself out of complications, right? That's another reason I use a posterior approach is I can get myself out of any complication that can occur intraoperatively. They're rare, but boy, you want to be able to do the right thing by the patient if that does occur.
Okay. Okay, with that, I think we've addressed most of our themes tonight. We had a lot of questions, so thank you for participating in our Q&A to all of those who submitted questions. There are several questions about our location. So you see patients at our Schoolcraft campus location, which, if you're not familiar with the Livonia area, is right near I-275 and 7 Mile. But we also have practices in Canton and Livingston and Ann Arbor. So there's a lot of locations, and all of them will be included in the follow-up email. So you can certainly find someone near you if Livonia is not. Go
Let
ahead.
me just say,
Yeah.
I'm blessed to serve in a group of just phenomenal surgeons. It's one of the reasons that I joined this group, because I trust my partners to do the right thing for people. Yeah, any one of us can take good care and provide competent care for management of the without surgery, and then when it comes time to make sure you get the right treatment that you need.
Yes, and I've actually taken my mom to our IHA location, so I can say that Dr. Pack is certainly right, that I have always had very good experience with our surgeons. So thank you so much, Dr. Pack. You're a wealth of knowledge. We appreciate you taking the time to talk through so many different questions and a really robust presentation. So look again for that email in in the next couple days with the recording, and have a good evening. Thank you, Dr. Pack.
Thank you. Have a great evening.